Okay, this is the next one. Again, a patient who had an acute coronary syndrome. It's again a proximal LED lesion. The left main looks reasonably good. Vishnu, left main probably it looks good. Shall we go with a 6? Okay. Okay, and now show the next image. It's a tram track calcification, a tight stenosis in the proximal LED, a significant calcification. The vessel looks little bit smaller than the other previous vessel. The previous vessel was much bigger. This looks little bit smaller. So that's the lesion near the diagonal and septal. Yeah, there is a lesion down. So probably we might need 2 stents, or probably a 48 should settle the issue. So what would be your strategy? Radial? Yes. We would prefer radial for this because the left main looks good and ostium looks quite roomy. We can go with a 6 front sheath, then six sheath and 6 guide, wire the LED, do imaging, then orbital atherectomy, then regular balloon dilatation and stenting. This appears to be a straightforward case. Would you have a different strategy? Yeah. This view probably again the left main. Come to the previous view. Show the previous view also. Here again you have a reasonable landing zone. No, there is no significant plaque at the left main LED ostium. So probably left main covering the left main may not be needed in this particular case. Spider. Next view. Do we have a next? Do we have? That's the cranial view. Next view. You can always have a reasonable landing over there. Wire and OCT catheter. Okay, run through. It's like it can be done either way. We have one parked over here always, and if somebody wants nearby, they can also take it. The cost is not too much. It's only 15 lakhs or so. 1.5. Now we'll go with the run through wire. Do an OCT pullback. Come cranial. Come cranial. Centralize. Keep a New York wire ready. Somebody is monitoring the saturation, right? Can you also tilt the head towards one side? The mask is obscuring the image. Can you? Get another run-through wire. Come to AP view, plain AP view to reposition the guide catheter. Okay. Now come to 1 second. Let me see the pressures. Pressures are okay. Okay. Now come to cranial view. Be ready with another. Okay, that's enough. Okay, we'll go with the OCT catheter. Tilt the head towards one side, left or right, so that the mask is out of the field of vision. Okay, OCT, are you ready? Okay, 20 cc syringe. And get ready with the orbital device also. Perch. Okay, Sini, vitte. Wire. രണ്ടിലും കൂടെ പിടിച്ചേക്ക്. It's not going through, so we'll do the orbital. We'll do the plate modification and then try to do the imaging. Okay, it's not possible. Pardon me? It was not looking so difficult. No, it won't go through. Okay, we'll take this out. Now give us the micro catheter. Micro catheter, the wiper wire. So we'll rely on the fluoroscopy to do the orbital atherectomy. We'll dwell more on the area where we have that fluoroscopic calcifications, more of fluoroscopic calcification. Okay, that's the microcatheter going through. Okay, give the orbital wire, wiper wire. It's much better. That's what we had been discussing today morning. That if you look at the wire as such, it's a nitinol wire compared to stainless steel wire of Rota. That's number one. Number two, if you look at the distal radiopaque marker, both are one and the same. Here it is 2.5 centimeters. The other one is 2.6, and Rota wire is 2.6 centimeters. Then if you look at the body, Rota wire is 009, here it is 012. So a little more sturdy, and because it's a nitinol wire, the trackability, the wire, the ability with which you can push it across the lesion, it's all much better compared to the Rota wire. So there are many advantages. This is the wiper wire flex. That is what is marketed in India. They have two wires, the wiper wire flex, which is a nitinol wire, and the other one is the regular wire. The nitinol wire is much trackable, it's quite user-friendly. The one that's marketed in India is the user-friendly one. Many times it can be used as a workhorse wire. It's so user-friendly, but only thing is it's 300 centimeters long, and so you find it cumbersome. So almost always we change it once we're done with the plate modification. Okay, the device. Sini, we'll concentrate on that calcified area. The wire hugging calcium we are seeing there, that is the area where we didn't go across with the OCT case. So that area we'll concentrate. Yeah, near the bend. That's it. So, So now we are ready with the wiper slide. Are you ready with the wiper slide? Is it flowing? We'll keep it, we'll bring the device till the near the Y connector. Purple, keep pushing, it's not coming. Okay. We'll keep the device till the crown till somewhere near the Y connector. Then we'll check all the parameters, make sure that the fluid is running properly. Then we'll position these things properly. Maybe one inch distal to the most distal end. We'll lock it. We'll keep it locked. This is the open position. The wings are open. This is the closed position. Then on off we'll check it. Then before that we'll always lock the press the lock button. This is a lock position. This is the open position. You can move forward. Basically, it's like you're opening the wings, ready to fly. That's how they say about it. Easy to remember. Now we locked it. We have kept the toggle button at 80,000 RPM, and we'll see. Always when you want to check it, keep it away from the drape. Okay, it's working. So now shall we go in? Okay. This vessel is not a very big vessel compared to the previous one. Basically, it's the push-pull technique. One person can do both the push as well as pull can be done by the single operator, like how we do the rota. It's moving. And again, while using a 6 French catheter, try to avoid puffing in between. Try to avoid injecting now and then, so that air embolism can be prevented. Okay, we are ready. Okay, Sini, we are ready. Now I'm locked the lock button. Okay. Yes. Distal, the most yeah, that is the area where we see the calcium, like keep the Cine. It gives come back 25 seconds done. Okay, we'll come back and then halt. Now we saw it's rather than keeping it, because it's looking more tighter lesion, rather than keeping the bar across the lesion, keeping the crown proximal to the lesion is always better, and it just jumped across the lesion. So it just says that it's a more tighter lesion, more difficult lesion to manage. So you had to give a gentle push. Once you do a gentle push, it just jumps across the lesion. So we are done with 20 seconds done. That is the area where we see the maximum calcium. You can listen to the pitch. There is a difference in pitch over there. You can also do the retrograde sanding. Yeah. That is actually difficult to make, but then while doing the 25 seconds, you can identify if there is a variation. If there is a difference, you can always identify the difference in the proximal portion and the distal portion. No, you wouldn't want to have too much of heat energy created there. regarding rota, even though they say you can do 20 seconds, we are very meticulous that we never do more than 15 seconds with rota. And even the waiting period with rota, they say that it's you just have to wait for 30 seconds. We always meticulously wait for 1 minute before the second burring. അപ്പച്ചാ കൈ താഴ്ത്തി വെച്ചാട്ടെ. Yeah, once we are done with the burring, last probably one pass we'll do it there, because that doesn't looks very significantly calcium. There is some calcium on either side of the wire. Finally we'll have one polishing over there. ST segments are okay. Blood pressure is okay. But that's very cumbersome, no? You have to remove this out. You have to go with you can also do it over the wiper wire. You can always do the imaging over the wiper wire, but then it's cumbersome. So once you're done with that, do the imaging. ഒരു ഷൂട്ട് എടുക്ക. ഫോർക്ക്. But distally, we wouldn't do anything more over there. Proximally, probably we'll go at higher RPMs now. No, we are sure that we have made some 3-4 passes. So whatever has to happen with the speed of 180,000, it is some volume reduction has been done. That is because whoever routinely uses Dr. Raj Dave and people from US, they are the fans of orbital atherectomy. They say that once you hear that the pitch is not different during the run, then you're sure that whatever it has to do, it has done. So now take it out, and that's the only way of understanding that. And the more number of passes you do, more the volume reduction that you achieve. Listen to the pitch. We started with low RPMs, 80,000 RPM, and we went. Now we've just gone up to 120,000 RPM. Anjana, we'll do one more. When it's a very difficult lesion, when it's an uncrossable lesion, here we don't feel it because it's not a very difficult lesion. But there are lesions wherein you tend to feel that it's not moving forward. That you understand that, and you push it across. Otherwise, you don't. Yeah, you get an idea. In a very difficult lesion, you get an idea regarding that. Very true. Here you're sure the proximal lady as we're coming back, it was not touching anywhere at all. That pitch was totally different compared to the distal half of the lesion. I think we'll stop now. There is some ST elevation. I think we'll stop. Glide assist. Okay, keep pushing the wire. Keep pushing the wire. Push. It shouldn't come proximal to the bend. We'll keep it further distally. Keep pushing it. As you keep pushing it, it just comes out. You don't really have to pull it out. Now, small NTG, a shoot, microcatheter, and we'll exchange the wire. Oh, it's come up. Okay, flow is good. Flow is good. You can see that there is a significant luminal gain over there. Even angiographically, it's very clearly seen. Now we'll take this out. Okay, now give us the microcatheter. Microcatheter, then the workhorse wire, then the OCT catheter. We'll hold on to the wire. Can you be the wire? Now the run through wire. Then the OCT catheter. Indiflator. Indiflator. Fourteen, 16 atmospheres. 16. Okay. Stop. OCT catheter. We'll do OCT. See the vessel size. Probably we'll pre-dilate with 2.75 balloon. Be ready with a 2.75 balloon, 2.75 into 12. Prior to that, we'll have the vessel size assessed on OCT. Aditya, you be ready with the OCT images. Finito. Now it's gone in without much of difficulty. Okay, we across the distal lesion. We'll have a quick OCT run. Then give some nitro also. There is some ST elevation. Once we are done with the OCT, ചെറിയ വേദനയുണ്ട്. ആരെങ്കിലും സംസാരിക്കോ പേഷ്യൻ്റ് അടുത്ത് വന്ന്? കുറച്ച് ഫെൻറ്റനിൽ 25. Okay, we are ready? Aditya ready? Yes, come. Live view. Okay. Yes, auto calibrate. Balloon ready? Okay, enable pullback. Activate. 2.5 balloon. Okay.
2.5 balloon. 2.5.
Give some nitro.
2.5.
2.5 is okay.
2.5.
Now look at the vessel size on OCT. Midazolam, we'll give very less midazolam because he was totally off after giving 1 milligram of midazolam. So just if at all 0.5 milligram only. ST settled down. Sir, it was basically because the imaging catheter was there. Because of the tortuosity, the vessel was straightened and there was no distal flow. So that was the reason why he had ST elevation and angina. Now it's settling down. We'll do a cine. Okay, Sini. I'll go there and see the images. Even the distal lesion at low pressures. No. Huh? Till osteo. Enlarge the OCT. Now we are looking at the longitudinal image. We are seeing the circumflex here. We are seeing the circumflex here. The left main looks okay in longitudinal image. And now we go from the distal LAD to proximal LAD. So basically it's a diffusely diseased vessel. Here the vessel size is around external EL to EL. It's hardly 2.5. So see 2.5 millimeter balloon dilatation. Distally the landing zone would be around 2.5. If you look at the entire length of the vessel where we'll have to stent from distal portion to the ostial LAD, it is around 40. It's around 42. So probably we'll go with a single stent 48 millimeters and settle with that. Now, so that would be the length. Now coming from the most distal portion to the proximal portion, here the vessel looks reasonable. The landing zone looks reasonable. Now this is more of fibrotic plaque, a speck of calcium at 2 o'clock position. As we come more proximally, this is more of fibrotic, no lipids at all. Huge amount of fibrotic tissue, some calcification at 6 o'clock position. 6 o'clock, 5 o'clock position, there is calcification. You are seeing some small microthrombi there. These areas probably the calcium, there is some plaque modification. This area it looks smooth, so there is some plaque modification that has happened over there. Then as we come more proximally, this is more of fibrotic, and there is an eccentric calcium at 12 o'clock position, but it seems to be more deep rather than into the intima. Here, this particular area, you're seeing significant area of calcium that has been shaved off. So much of sanding has happened. That is probably the area where we had the maximum sanding. It's clearly seen. Now the lumen also looks reasonable. Here again, probably these were the nodules that were preventing the initial catheter from going in. Here you can see that this particular nodule at 12 o'clock position, nothing has been done. This also nothing has been done because the imaging catheter appears to be away from that. So nothing much has been done over there. And this is one area. See, initially we were discussing regarding cutting a hole in the vessel. See, now you could see here that this catheter is actually, the catheter is actually hugging on to this vessel wall, and probably it is reached till the media. So this is probably the area where one could have a perforation because it's away from this particular, probably the imaging catheter should be somewhere here. It's very close to the vessel wall. Yeah, eccentric. So that is where probably one could have a whole perforation or so. And again, this particular area, you have seen that there is significant calcium that is being shaved off as we come more proximally. So again, at these particular areas, we are seeing the calcium that is shaved off. Here again, it is actually going towards the adventitia, that is actually dipping more towards the adventitia, and more proximally, it looks, this area, it looks, there is eccentric calcification, but when you dilate with a balloon, probably these areas should break. See, we have done with the balloon dilatation.
Yes, sir.
Shall we do one more OCT run before stent implantation? Okay. Just to see what has happened with balloon dilatation. And now we have reached the left main. Left main looks quite roomy. Here we'll probably come till, yeah, LAD is diffusely diseased. So we'll go with a 2.5 48 millimeter stent, and proximal vessel, the LAD near the ostium, it appears to be a much bigger vessel. 3.3, probably we needn't be very aggressive. Probably we'll be post dilating with a 3 in the proximal portion and 2.75 in the distal portion. Till the ostium. I will come to that again. Here also it's 3.2. So 3.3 would be the post dilatation balloon for the proximal 3 for the proximal vessel and 2.5 for the distal vessel. Now this probably should be the landing zone. Here we are seeing all the branches. The ramus is seen over here. The circumflex is seen over here. If you come back, probably till the ramus, we need to land it right. Here the lumen is really
Gradient.
good. So probably this would be a millimeter into the left main. A millimeter into the left main would be that we can safely do it with the this imaging also, fluoroscopic image also. This is what we commonly see with orbital atherectomy, post-orbital atherectomy. In the distal areas where you have fibrotic lesion, it has got nothing has been done over there. Even though the lumen is too small, you could see that its luminal area is only 2 millimeter square. Still nothing has happened. So primarily the differential cutting that helps. Here again you can see that there is a significant smoothening of the calcified nodule there. There is significant sanding that has happened. So that's it. Now we are doing a repeat OCT, right? Isn't it, Sini?
Ready, sir.
Okay. Now be ready with the stent also, 2.5 into 48.
Right.
Yeah.
What a clip. Enable pull back.
Yeah. Seriously. Yeah, we have it in the shelf. Today we would want to use
Activate.
cost. Catheter edukam. I'll come that side. We have seen multiple dissections there. We'll rotate it in such a way that in the longitudinal view we are seeing the circumflex as well as ramus. So that's this is the ramus, this is the circumflex and ramus. So we would go inwards. There is no dissections at those particular areas, but as we go into the LAD, we are seeing the balloon related dissection, and as we go further in, again those dissections are clearly seen. The calcified nodule is seen at 5 o'clock position. At 11 o'clock position, you are seeing a calcium that has been shaved off, that's smoothened out. Smoothened out. Yeah. Now here again you are seeing a small fracture over here, and the dissection and the fracture. Then again here the volume reduced area, the calcium nodule wherein it has been shaved off. So you tend to see these sort of microthrombi most of the times, and some small flaps also, it tends to get raised after orbital atherectomy. Here you are seeing some fractures there. So distally, I think we'll go with the stent. It should go in 2.548. Then 2.75 and 3 mm NC balloons. Pardon me? 2.75. Distally, it's only 2.5, and proximally, it's coming to 3.2, 3.3. So proximal, we'll go with a 3 mm post dilatation, and in the distal half, 2.75 at low pressures. In the distal, 2.5 will be safer. If we go with a 2.5, then we can go up to 18 or 20 at most. If you go with a 2.75, probably 14, hoping that we'll have a little more luminal gain at lower pressures. Okay, distally we are covering. We'll take a small cine. Now comes spider after this. Okay, distal landing zone looks good. Spider. And after that, we'll start with a 3 mm post dilatation first, and then 2.75. Should we go 1 mm distal? Because it's actually more like an early diagonal, maybe 1 more millimeter distal. Looks reasonable. Okay, there probably we can post. Okay, we'll go up. Anyway, we'll go up. Okay, so now 3, 2.75, and finally 8. Yes. 10. 12. Negative. ഒരു ചെറിയ ടെസ്റ്റ് എടുത്താ സിനി ബലൂൺ ഡയലേറ്റ്. Pull back couple of millimeters and then go up to 16, 18. 16, 18. Negative. So now we'll take this out. A 3 millimeter for the proximal LED, 2.75 for the distal LED, and then be ready with a 3.5 also, just for the right at the ostium. 3.5 shorter one. Yeah, okay, come cranial. Come to cranial view. Yeah, 2.75 ആണ് ആദ്യം എടുത്തേ. Then we'll go to. Okay. Okay. 2.75 for the distal vessel. It's an Oxford balloon. We'll come back little bit. Okay. Low pressures 12. Negative. Ah, 14. Negative. 16. Negative. 18, 20. 20. Negative. Okay. Okay, looks okay. We'll take this out. 3 balloon and 3.5 balloon. Three balloon. Then just for the ostium, we'll go with the 3.5 at low pressures. 3.58. Yeah. Yes. The next patient, which one is the next patient? Shekharan. We'll complete the next case and have lunch, right? Push ചെയ്ത് ചിലപ്പോൾ ഇത് ഇളകി വരും. Cranial, come cranial. Okay, 14. This 3 balloon. 14.
14, sir.
Negative. 16, 18. Negative. 18. Negative. Come caudal. 20. Now the 3.5 also negative. .5 and OCT.
Reflect.
Okay. 8.
10, 12. 12. Reflect.
അല്ല അത്രയും ഡിസ്റ്റിൽ പോണ്ട അവിടെ ചെയ്തോ
12.
just the ostium. Just the ostium. Distally it's only 3. There it's all only 3. So
What?
Just the ostium. We're not at the ostium. We are not. Okay. That area.
What?
1 millimeter back. 1 millimeter back. Yes. 12-14 and we'll stop. Okay.
Reflect.
Negative. See, what is a guide on the reposition? Okay, now we'll come. Okay, now the OCT catheter. എല്ലാം കൂടെ ഒന്നരയല്ലേ പറഞ്ഞു. Yes. Shall we come cranial? Anna. They have financial issues. ഇല്ല 1.2. If the CT catheter doesn't go in easily, it's primarily because it's an aux catheter. Now we can always reposition the guide, reduce that curve over there. Now once you reduce the curve over there, then mostly it will go in. Come AP view. Come to AP view. Now come to cranial view. Okay, we leave it there. We won't go much distally because that beyond that bend you wouldn't want this catheter to go. So we can image the proximal vessel very clearly. The ostium can be seen very clearly. അപ്പച്ചൻ കൈ കൈ Okay, we'll do the imaging now. You're ready with the OCT? Live view. Auto calibrate. Okay. Now ready? Enable pullback. Okay. Activate. Okay. We'll give some nitro. You tend to see these sort of SWAP artifacts. These sort of SWAP artifacts when you work with a guide catheter, which is not actually, if the curve is very smooth into the left main, you don't see the SWAP artifact. Here what we saw is it is going into the aortic cusp, coming like this, and then the imaging catheter. So when you have multiple bends, you tend to see these sort of SWAP artifacts, and mostly in calcified lesions, that is where you see these sort of SWAP artifacts. Now we'll start looking at the left main bifurcation. So here as we go, left main looks okay. As we go into the LAD, this area we are seeing that the struts are seen floating in the left main. Now we are seeing the circumflex and ramus over here. So not too much into the left main. Here again, the proximal areas, you are seeing that the struts are very well opposed. As we go in, main intention was to have a look at the LAD ostium. The luminal areas are reasonable. Anything above 5 is acceptable. In the proximal LAD, it's coming to 7, 6, 7 and all. But as we go distally, 5 should be acceptable for us. Here, it's showing such a low luminal area primarily because of the blood artifact over there. Then as we go distally, it's 4, 3.5. Again, blood artifacts there. Our position is good. The luminal areas are reasonable. We are into the left main. We'll come to 3D bifurcation. 3D bifurcation may not look good when you have this sort of SWAP artifacts. See, that's how the 3D bifurcation would look like. Because of the SWAP artifacts, you're not seeing that. Okay, so that's the circumflex and ramus ostium. The stent is certainly coming couple of millimeters. That's what we precisely wanted to have. But anyway, there is no compromise of the circumflex as well as ramus ostium. Reasonably good position. That looks. Anyway, we are post dilated with a 3.5 in the most proximal. We don't have to do anything more over there.
Caudal?
It's a blood artifact.
Final cranial?
Angiographically also it looks good. This 1 to 2 struts is never a problem. We have seen problems with 5 millimeter struts protruding into the left main. That is always, in future you can have trouble with this 5 millimeter, 4 millimeter, 3 millimeters, which is not well opposed. You can have problem in future. Many of them, they 1 to 2 millimeter, that's what we would prefer to have. 1 millimeter into the left main. That particular area you wouldn't expect any opposition. No? If it's 4-5 millimeter, obviously you'll have to put in another balloon and dilate it. Yes, most of the situations semi-compliant would be preferable. But just 1 or 2 struts into the left main, we would prefer to have it. Then again, you cannot further dilate it with a 4 millimeter balloon over there. Always safer, always safer. Here, here again may not be challenging, but we've had situations wherein 5 millimeters across the circumflex ostium, patients had restenosis, that perforated restenosis. We had to go through the strut into the circumflex, open it up, do a mini culotte like from the circumflex back into the left main. Those things have happened, but then with just couple of struts, usually we don't see, on follow we don't have any problems. Maybe tomorrow during discussion I can show both the cases. A patient with 5 millimeter stent protruding into the left main, developing stent thrombosis, I have an example, and even a 5 millimeter into the left main, the circumflex ostium had got in perforated restenosis, that whole restenosis. Patient has come with a dominant circumflex pulmonary edema, wherein we had to do a mini culotte from the circumflex. So those examples I have. Tomorrow probably we can discuss those things. No. Whatever you do, at times you tend to miss the ostium. But rather than missing the ostium, and again, if you have some lesion in left main, you're happy, you can have the stent all the way. But then without any problem in left main, why would you want to cover the entire left main? But for future intervention, having the stent way back into the left main is always safe, not protruding into aorta.